roll, scene 4, take 1, second sticks, mark.
Okay, can I buy you some new headphones?
I got some other speakers I can get.
Yeah,
You
they're
just
right
to the black YouTuber's house. You bring the broken headphones. You afraid I'm gonna steal them?
Yeah, exactly.
Is that what it is?
That is, you nailed it.
You
It's my hidden, my
racist.
unconscious bias.
Racist.
Set and
Welcome back to Medicine D. Welcome back to Medicine D. Oh, that was good. Okay. Hey guys, welcome back to Medicine Deconstructed. I'm your host, Dr. Jay Rutland. I encourage you guys to mess around with your production team because I think it's kind of funny. Listen, there are multiple reasons why I believe I became a pulmonologist, but there's one case that stands out. This case happened several years ago, and I want to talk about that case, what it taught me, and what it means to me. When I was a resident, there was a particular case that has stuck with me forever. There are multiple reasons, but I believe the main reason is this case taught me how to become a true expert and how to perform a thoracentesis. I was a second-year resident rotating on the pulmonary service for the first time. I thought I wanted to do pulmonary and wanted to be a pulmonologist, but I wasn't 100% sure. Here's the case. A 57-year-old male with a history of renal cell carcinoma, status post-nephrectomy, kidney coming out, and IVC thrombectomy. He had increased abdominal distension and shortness of breath. Here's his chest x-ray. That's interesting, right? He has a loss of both the right and left hemidiaphragm. The cosophrenic angles are blunted, and all of these findings are consistent with pleural effusion. Easy. But are we done? Hell no. Here's the thing. The pleura is sort of a saran wrap that covers the lung and the chest wall. The parietal pleura lines the chest wall, and the visceral pleura line the lungs. You can see the difference here. One picture is a cartoon, and the other is an actual histologic picture. Now, a pleural effusion is fluid within the pleural space. Typically 12 cc's of fluid is produced per day. When more fluid is present, we have to understand why. After draining the pleural fluid via a thoracentesis, we've discussed this, or I have shown this before, we must send the fluid off for studies. We are differentiating between a transudate and an exudate. We do this by using Light's criteria. Pleural fluid to serum protein ratio greater than 0.5, pleural fluid LDH level greater than 2/3 of the upper limit of normal of the serum, pleural fluid LDH to serum LDH of greater than 0.6. Essentially, you want to know if the fluid is full of protein or not. You can see how simple this study was. He looked at a bunch of people, knew their diagnosis, and looked at the ratios. Once you determine it's a transudate or exudate, the differential is easy. Transudates usually represent a patient with heart failure or some protein wasting condition like cirrhosis of the liver or nephrotic syndrome, a protein wasting kidney disease. Exudates represent infections, cancers, autoimmune situations, or chylothorax. We also look at the cell count and differential. I will always bring immunology into my presentations, and you know this. When you look at the fluid under a microscope, you can see white blood cells, and typically pleural fluid will have 75% macrophages and 23% lymphocytes. If you see eosinophils, you have to think air or blood is present and maybe malignancy. If you have a lymphocyte count greater than 50% with B cells or T cells, think tuberculosis or malignancy. If your glucose level is low, this could be bacterial infection or a rheumatoid arthritis pleural effusion. If your pH is low, which means it's acidic, it can be a pneumonic effusion, an empyema, esophagus rupture, urinothorax, that happens, or paragonomyosis, which is a flatworm that infects the lung after eating undercooked or raw crab or crayfish. I eat that all the time. Chest tube placement should be considered if infection, lower pH, or obviously if there's air in the pleural space, a pneumothorax. So back to our case. I performed about 6 or 7 thoracenteses in this patient. This is where I learned how to do the procedure so well. The fluid had like this strawberry, milky appearance. We looked under the microscope and stained it for lipids. It was positive, and we determined it was a chylothorax. This happens when the lymphatic drainage system is damaged during trauma, probably the surgery, and leaks into the peritoneal cavity and the pleural space. The cisterna chyli is an extension of the thoracic duct which terminates near the subclavian. This is the freeway system for all the white blood cells. When it's damaged, this can happen. You get leakage. It's treated with ligation, or with medium chain fatty acid management. Lowers the amount of fat. I thought this was a case that taught me a lot, and it's one that sticks out in my mind. Pleural management is important, but it starts with understanding the visceral and the parietal pleura. Again, I'm just here arming you with information. Please come back next time for more ammunition. I'll see you next time here on Medicine Deconstructed.